Thank you very much, Colin. Thank you very much for the invitation to talk. Hopefully, what we're going to talk about today is relevant to anyone that works in creating or generating health information that's going to be accessed by patients. That's the frame of reference that we came with. I do have a couple disclosures. I have previously served as an advisor to Genomic Health, and I have active research support from the institutions on there. So to frame what I want to talk about today, this is kind of a concept talk. There is some results that we're going to discuss, but in some ways this is sort of a work in progress conversation. It's an emerging idea that I think is important, and I think it's relevant to a lot of the people in this room. And it emanates in recent legislation that promotes increasing patient engagement in access to their healthcare documents. I think it's framed by the current state of health literacy in the United States of America, which is not an incredibly impressive state. We have done some background work that has been sort of foundational to a project that we're working on to create patient-centered pathology reports. And so the end goal here is to create patient-centered resources that they could access through things such as a personal health record. So I'd like to discuss how some recent federal legislation to promote patient engagement might influence how we would think about the health information documents that we produce. So HITECH stands for the Health Information Technology for Economic and Clinical Health Act. This was part of ARA and subsequently the ACA, and this came out in 2009, and it had a couple of foundational goals. It has this overarching goal that I think many of us think is unrealistic, maybe in my lifetime, but a large network of interoperable electronic health records. We struggle just to have an intraoperable electronic health record, but I think eventually that's a wonderful, maybe achievable goal. But importantly, this wasn't simply about adoption. They introduced this concept of meaningful use. So not only are you going to adopt an electronic health record, but it's going to be implemented in a way that actually is meaningful to the quality of the care that we deliver and to engaging patients in their own health care delivery. So this is just a simple graph that shows the rapid uptake of EHR adoption by individual professional physicians as well as individual hospitals, such that now over 80% of U.S. hospitals employ electronic health records. That's compared with 2008 was not that long ago. In 2008, that number was around 10%. So there's been an incredibly rapid adoption of qualified electronic health records in just the last 5 or 6 years. So what does meaningful use mean? Well, these meaningful use criteria were developed with a period of accessible public comment. So it means using your electronic health record in a meaningful way, using it to exchange health information in a way that is associated with improved quality of care. It should be used, something that we have to do as clinicians a lot is submit quality measures. So we have to submit these measures that sort of, in some ways, judge the quality of the care that we delivered. They're not necessarily that relevant to the eventual quality of care received, but it's part of our reporting requirements at least in urology. So an example of meaningful use criteria, there are 2 stages of meaningful use. The first stage is really just about implementation of electronic health records. It's the second stage that we're coming upon in the next couple of years that's focused on active patient engagement. So here's an example of something that I think is very relevant to how we need to think about our health information documents. That one of the specific criteria for patients getting ambulatory care is that more than half of them in your local EHR who request a copy of their health information documents receive a copy of their laboratory result, their pathology report, their medication reconciliation documents within 3 days. So it's not enough just to make these things part of your EHR. They have to be accessible to patients. And that includes things like the results of lab tests. And I'm not sure what this language means, but it says that they have to be incorporated into your electronic health record as structured data. So there has to be some structured format to the data that patients can access. So importantly, patients are going to view and they're going to read and they're going to want to understand these documents. But there may be an accessibility problem. It may be very challenging for many patients, for the average patient, to access the documents that they're going to be exposed to. So I want to start just by examining the average capacity of a U.S. healthcare patient to process the information that's included in health information documents. I heard a great analogy when I was in medical school, and for the MDs in the room, when you think back to the first year in medical school, it's an onslaught of information. And the analogy I heard was that your first year in med school is like being immersed in a foreign country for an entire year because you learn so much new vocabulary. And then we learn to process and implement that vocabulary as if it's standard, as if it's rote for everyone else. But it's really not. So the first big survey of literacy, just adult literacy in the United States, was something called the NALS study, the National Assessment of Adult Literacy, and the survey was implemented about 25 years ago and published about 20 years ago. It did not focus on health literacy, but it gave us a snapshot into the literacy capabilities of the average American. Surprisingly, among elderly Americans, almost half were considered functionally illiterate. So what does functionally illiterate mean? It means they're in the lowest reading level category, and they have difficulty processing simple written information. That translates to about 40 million Americans who couldn't perform basic reading tasks, which is pretty alarming. If you add in the patients that have marginal literacy, that brings the total to about 90 million Americans. This is 20 years ago, but still 90 million Americans who struggle with basic understanding of written information. There are some not so surprising underserved groups, people of low socioeconomic status, people with lower education level, and those people, unfortunately, that are burdened by a greater number of health problems. So people that probably need a greater literacy level the most. And so this study concluded that the average American reads at about a 5th to an 8th grade reading level. So this is taken, as many of these slides are, from a presentation that one of our residents gave, Matt Mosinen. And this is a paragraph of content that is written at a 5th grade level. So if you think about trying to craft a document that is written for sure, almost every patient that you would view or see, this is the language that you would want to construct. So it was updated about 10 years ago, and it actually included a health literacy component this time. So now we can get at our average patient's ability to process health information. And based on this sampling strategy, it was a population-based sample, it's estimated that about 30 million adults in the United States of America have below a basic health literacy level. If you translate that into how that impacts their health outcomes, the majority of these patients who have low health literacy also relate their actual health as being poor. So, this is probably a chicken or the egg, but we definitely have a problem where the patients who are most in need of being capable participants in their care, of having an acceptable level of health literacy, are the patients with the poorest health. When you look at elderly Americans, patients who are 65 and older, there are certainly some consequences on their health outcomes. And these are patients that tend to have multiple chronic diseases, patients that are taking multiple medications per day with the inherent documents related to pharmaceutical instructions, directions for taking your medications. Almost half of these patients have challenges with literacy. 1/3 of Spanish-speaking patients have declared inadequate health literacy, and 1/4 of English-speaking Medicare beneficiary-aged Americans have inadequate health literacy. Well, what does that mean? It means that many of these patients can't interpret blood glucose levels. That's a particular challenge in our diabetic population, obviously. That means many patients can't understand the correct timing for dosing their prescriptions. And as you would expect, and similar to what we found in generic adult literacy, non-white, non-English speaking, elderly, and lower socioeconomic status Americans were at greater risk for inadequate health literacy. When you specifically target those patients that are at higher risk for being underserved, so a low socioeconomic status population, now 1/3 of patients can't even process radiology procedure instructions that were written at a 4th grade level, which is particularly alarming. When you try to talk about appointment slips and informed consent documents, these are particularly inaccessible documents to many patients. When you look at their actual outcomes, well, patients with poor health literacy have worse glycemic control and a higher risk of end organ diabetic complications. Asthmatics are more likely to improperly use their inhalers, and that can lead to more frequent emergency department visits. Hypertensives have less knowledge about their disease and the potential lifestyle modifications they can make to attenuate the severity of their disease. This can lead to noncompliance with your prescription medications. It can lead to increased ED and hospital admissions. And unfortunately, of particular challenge, these patients also tend to disguise or hide their deficiencies with literacy and health literacy. Not that dissimilar from the stories we hear about the superstar athlete who made it through college at the University of North Carolina without an ability to read at a 3rd grade level. In urologic disease, which is my area of expertise, patients with lower health literacy have a higher PSA at diagnosis of their prostate cancer, and by proxy, they have a higher risk for having metastatic disease at presentation. They have, not surprisingly, a decreased ability to participate in shared decision-making when trying to understand their prostate cancer treatment options. And a lot of the documents that we use to assess patient-reported outcomes are written with a reading level that is inaccessible to many of these patients. So if we're going to approach this problem, we think that patients are going to have increasing access to their health information documents. We think that the average American probably cannot access the content contained within these health information documents. And so we wanted to identify efforts to target the patient as an audience of these health information documents. So this is a review that Dr. Mosanen conducted recently. And so what we wanted to do was a systematic review to identify the target audience, and where we started was with pathology reports. And there are a lot of natural reasons for that. And this might inform efforts to develop patient-centered resources around disclosure of pathology results. So our goal was to identify the target audience of these reports and identify efforts that have been made and documented in the literature to develop patient-centered resources for these results. So we chose as our starting point the commonest cancers in men and women. We did a search strategy where we combined these cancer terms with a bunch of terms related to patient engagement, patient-centered outcomes research, and the substrate that we were looking at, which in this case was surgical pathology. And so from these results, we identified 4 pretty consistent themes. There are a lot of efforts made to standardize the content of pathology reports, and a lot has been written about the heterogeneity of pathology reporting, and frankly, some non-compliance with current pathology reporting standards. And that relates to variation in pathology report content. When a lot of these articles refer to communication, they're talking about communication with clinicians. There is already a barrier where many clinicians cannot understand the content of a pathology report. So if a clinician can't understand the content of a pathology report, how are they going to be able to translate that information to a level that a patient can understand? And lastly, a lot has been written about quality improvement, and that mostly relates to, again, standardization of the pathology report content. Importantly, we couldn't identify anything that addressed the patient as a stakeholder in these pathology reports. We did identify a couple of sort of FAQ documents, frequently asked question documents, but when we tagged one of those to assess its readability level, it was written at a college level readability level. So even a for patients document was not necessarily written for patients. So what about when we look at actual pathology reports? We know that patients are not a target audience of these reports, So what if we assess their ability to read them independently? Is this an effort we actually need to make? And this is another project that Dr. Mosanen has been working on. The other thing is, not only what is the current status of pathology report readability, but are there some obvious opportunities to make modifications that might make these documents more simple and more accessible to patients? So we reviewed 5 pathology reports from several GU cancer procedures here at the University of Washington, and we looked at kidney cancer, bladder cancer, prostate cancer, and testis cancer. And we had a couple of hypotheses. We hypothesized that there is some content that is a standard part of these reports that drives obstructions to readability. And so we hypothesized that the gross descriptions of the specimen certainly confound readability. Descriptions of the immunohistochemistry, which might be incredibly important to how you arrived at the diagnosis that is listed in the summary part, but may not be important to that disclosure between clinician and patient about the pathology report content. And we also hypothesized that histologic terms may be a driver of sort of adverse readability, I guess we might call it. So this is a distillation of what we found in the reports. And in the left-hand column, second from the left, is the readability of standard reports. And the standard reports have a minimum reading level of about 10th grade, which actually is surprisingly low. But readability is a little bit of a complex formula, and so if something has a lot of content that is written with monosyllabic words, it's going to have a lower readability, even if those words might sum to complex content. When you simply omit, and this is modified report 1, you simply omit gross descriptions and immunohistochemistry results, then that shows you alterations in the readability level. And this readability level translates to a grade level. So when you see that number, a 9.8 means essentially a 10th grade reading level is required to understand this report. When we omit gross descriptions and we omit immunohistochemistry, and then we take the histologic terms and we replace them with lay language terms. So an example would be we replace renal cell carcinoma with kidney cancer. That changes the readability somewhat. And so there have been some significant changes where kidney cancer documents go from a readability level around 10th to 11th grade to around 9th to 10th grade. And technically that's a statistically significant difference, but it may not be a functionally communication-aided difference. Conversely, however, some of the reports actually became more difficult. They became less readable when you made these simple deletions in the content of the report. And so what that tells us is that, number one, these reports in general are written at reading levels that most patients can't access. And we learned from our review that that's because patients weren't considered to be a target audience of that. So that's not that surprising. When we try to just simplify these reports through deletion, so simplification through deletion, we may improve readability somewhat, but we might actually confound readability for some other reports. So if we're actually going to target patient-centered resources and development of patient-centered pathology reports, it's probably going to require a more involved process than simple deletion and maybe translation into some lay language. So this is where we kind of transition into a bit of a work in progress. And this is a concept that Larry True and I started working on a couple years ago, just over lunch conversations. And the idea is, can we create documents that are easily understood by patients without sacrificing the important content that is important to the pathologist, that is important to the clinician, and that is frankly relevant to the patient? So we had a number of objectives. One is, well, we need to know what experts feel are the truly valuable components of these pathology reports. Number two, we need to understand, if we take those important elements, how we can construct formats that are relevant and understandable to patients. And then lastly, can we show that this actually has some positive value to patient care? The pathology report is used in the disclosure of a cancer diagnosis or maybe of a cancer recurrence. And so it is sort of a moment in time document. So we don't anticipate that these documents are going to change drastically, long-term cancer-specific health outcomes. So what are the outcomes that we can look to that might show us that these are meaningful documents? So some background. I work with a network of patient support groups, prostate cancer patient support groups in the Puget Sound area. And from that, we've sort of crafted a patient survey network. And so when we have a research question, like, for example, are patient-centered pathology reports even a good idea? Is that something that patients want to see? We have the ability to outreach our network of patients with prostate cancer to get some of their viewpoints. And this is just a quick sort of back-of-the-napkin survey where I asked the support group leaders for 5 area support groups what they thought was their patients' knowledge of their prostate cancer diagnosis. And the reason I asked about this is because as part of that work with prostate cancer patients, I often go to these support groups, and the first part of these support groups is usually devoted to new patients. And so these new patients will introduce themselves, and they're talking about their diagnosis, and they don't know what we think is just basic critical information about their diagnosis. So they know they have prostate cancer. They don't know what the Gleason score is. They don't know what the PSA is, yet they're at this support group to get advice about what treatment they should pursue. And without that information, it's really hard just for the support group leaders to counsel them appropriately. So I asked them what they think most patients know about their new prostate cancer diagnosis. So most people know their PSA. The PSA is it's like almost like a badge that a lot of these men have to wear. Because the PSA is why they had to go to the urologist in the first place. Their chief complaint for seeing their urologist is my PSA is 5, or whatever it may be. But maybe half they think of patients know their Gleason score. Fewer than that know how many biopsy cores they had were positive for cancer. And fewer than that were given some sort of representation of the severity of their cancer through a risk category. So for prostate cancer, we have a pretty simplified risk scheme where patients are low, intermediate, or high risk. And most clinicians use this risk scheme, but very, very few patients appear to know their risk category. So then we surveyed our sort of patient survey network, and within about 48 hours we had over 50 responses. And we just asked them in general, how well did you understand your biopsy, your prostate biopsy pathology report? And more than half had at most somewhat of an understanding of their prostate biopsy report. So then we asked them about this concept of a patient-centered pathology report. If I were to create a report that was generated in part through devoted input with patients, what aspects would this benefit in terms of your prostate cancer care? So a lot of men said it would help them understand their diagnosis, and it might help them communicate with their doctor. There may be some other ancillary benefits like active role in their health care, but importantly, not a single respondent said that it wouldn't help at all. So at the very least, it's going to help with something if you have a report that actually has content that you can understand. Now, importantly, and this is where a secondary hypothesis comes into play, so we think about patients as our primary audience for this idea. However, there may be benefit to clinicians as well. So in a survey where investigators inquired about clinician knowledge of pathology report content, about 1/3 of clinicians are challenged to correctly translate the information contained within a pathology report. This may be something where we think of the patient as a challenged stakeholder in this concept, but the clinician may be a bit of a challenged stakeholder as well. So there may be benefit to the clinician as well. So we hypothesize that if we implement these reports, it's going to impact greater knowledge at that initial discussion about a new cancer diagnosis. It may lead to greater retention of that knowledge at follow-up. We think that patients in particular would have strong preferences over these more lay language reports compared with standard reports, but it also may have an impact on clinicians. They may perceive better communication with their patients. They may have a better understanding of the jargon that is sort of part of their rote conversation with patients and may learn to avoid some of that jargon. So they may feel that they have a better translation of cancer information with their patients. So for this pilot, we selected bladder cancer for a couple reasons. Number one is Dr. Mosonen is very interested in bladder cancer, so that's number one. Number two, bladder cancer is very common. It affects an elderly population, which we know is at risk for poor literacy and poor health literacy. The risk factors for bladder cancer, number one being smoking, but number two being environmental exposures that are most common in the chemicals industry, leatherworking industries, things that are clearly associated with blue-collar jobs and lower socioeconomic status, predisposes, again, this population to lower literacy and lower health literacy. And the treatment plans can be very complex, and those treatment plans are directly sourced from the content included in that pathology report. If you have low-risk, non-muscle invasive bladder cancer, you're on surveillance. If you have a high-risk muscle invasive bladder cancer, you have to choose from among various challenging and complicated and aggressive treatments. So how are we going to approach this? So we convene an expert panel, and that expert panel is going to review existing pathology reports in order to identify clinically important elements contained within these reports. And then we're going to take that expert panel information, and we're going to approach a patient advisory board that's been recruited from UW bladder cancer patients, and we're going to say, these are the things that experts think are important elements of these documents. How can we frame these results in ways that patients can understand? And from that, we hope to generate sort of a candidate patient-centered pathology report that we can pilot in clinical practice. So we worked with local experts, UW, SCCA, urologists, pathologists, medical oncologists, researchers, but we also worked with national experts from the Bladder Cancer Advocacy Network. I work in a working group called the Patient-Centered Outcomes and Policy Working Group with Beacon. So we worked with national experts as well. And we did something called a modified Delphi process. So a Delphi process, like the Oracle of Delphi, is designed to get input from everybody. So if you put 10, even a smaller number, 10 bladder cancer experts in a room and you ask them to tell you what's important content, all you're going to get is who can kind of shout the loudest. So what you do with a modified Delphi process is you solicit this information from individuals, and then you collate that information and you reframe it so that participants can't recognize their own statements, and then you redistribute it to your participants and have them revote. So it's sort of a two-stage process where you make sure that you get input from all of your participants. And so this is the second stage, and if you look at the bars that are in light purple or yellow, it tells you the elements of a pathology report that are definitely most important. And this list started out with about 10 things and then got winnowed to about 6 things for the second stage. And really for bladder cancer, and this is partly why we selected it, it's very simple what impacts the therapeutic decisions we make with patients. It's the histology of the bladder cancer and the stage and the grade of the bladder cancer. And so this is the information that we are going to take now to our patient advisory board to generate candidate reports. But we're also challenged to think about how we're going to consider the clinical benefits that we think might be yielded from implementation of these reports in clinical practice. So we hypothesize that knowledge and retention will be benefited. We hypothesize that patient-doctor communication, which we can measure with a scale called the patient-doctor interaction scale, will be benefited. We definitely think that patients and even maybe clinicians are going to rate these reports as useful in their clinical practice or in their personal health care. And it's possible that if we have an opportunity to observe the language that's employed when these reports are discussed in clinic, that we're going to see less use of jargon. Importantly, these reports are not designed to replace standard content, and that's important. This is not an either-or, it's a both-or standard. So the idea would be we give patients the standard report plus the patient-centered pathology report or the standard report alone. So I think the way legislation has moved in the last 5 years and the way healthcare delivery has matured and become, frankly, more accessible to patients. I get emails from patients all the time. Patients email me with their results before I've had a chance to view their results. I think we need to rethink how these results are framed, and we need to think about the patient as an important audience of these health information documents. We've started by targeting pathology reports, and it seems like there's a real opportunity there because these reports are certainly written at a language that can even confound the ability of clinicians to interpret the information contained within. But I think the story is clearly yet to be written. So if we were to come back in a year, hopefully we would have some pilot data to show you about how these reports might be associated with improved clinical care or somehow better health outcomes. But I think it's something that might be relevant to anyone that's working with health information documents that either now, already, or in the future are going to be accessible to patients. because it'd be nice if those documents actually were readable by patients. So this is a project that's had a number of collaborators along the way. Dr. Mosanen has devoted his research year to working in this research space. Dr. True has been an invaluable collaborator. Dr. Lavallee is a patient engagement expert, so she works with her own patient advisory boards and is great with focus groups and qualitative methods with patients. And then Drs. Wright and Vacar Lopez have been involved with their clinical expertise, and Dr. Holt is our biostatistician. So I talked really fast, I'm sorry, but does anyone have any questions? Thank you very much.
So in a lot of our lab medicine reports, we sort of get this anecdotal idea that less is more in many cases. So as you lower the grade level at which something is taught, does it take more words to say the same thing with as much nuance? Or when we do that, do we actually convey less information?
That's a great question. So we have gotten very mixed feedback from clinicians about this idea. Most patients that we approach about this idea are very enthusiastic about it, but most clinicians are very wary. Number one, they're worried that it's going to take away content that is important content. So if we change urothelial cell carcinoma to bladder cancer, well, we might be able to translate that as urothelial cell carcinoma, but what if it's a variant? How are we going to convey some of that subtle information but still put it in patient-centered formats? And that's where I think it's important to think of these documents as ancillary documents, not solitary documents. And so I'm not sure. I know that when we simplified, for example, prostate biopsy reports, which by necessity have several elements to them because there are usually 12 cores or 6 pairs of cores or something. So there's going to have to be a lot of content. How to make that simpler without writing more is definitely challenging. So I don't have an answer yet, but I hope to soon. But it's definitely something I'm wary of. Corinne? Oh, sorry.
Anyways, I mean, some of the data you showed on adult literacy is from a while ago. Do you know what the trend, are there any, what's the trend? Is it towards worse or better adult literacy?
Definitely improving. Well, it's
Repeat the question for
oh, sorry. So the question was about trends in health literacy. So the first information we showed, and that's really what informs this still kind of commonly promulgated figure that the average American reads at a 5th to an 8th grade reading level. That's from 25 years ago. The updated data is from 10 years ago. So the question was, is that trend improving? Can we anticipate that 10 years from now, health literacy and adult literacy will be improved to the point where some of these concerns are not as relevant, some of our reading level concerns are not as relevant, and I think that's a great point. I mean, I think the technological capability of young kids these days is far superior to what it was definitely when I was a kid. And so people, I think, are exposed much more to written content than they ever were. At the same time, that written content is being sort of distilled down and simplified to the point where 140 characters is supposed to embody a complex intellectual thought. So I don't know. I think some aspects of it are going to be better and some aspects of it are going to be worse. LOL. Sorry. Anyone else?
Tom, do you have any sense of whether the use of templates is going to facilitate communication or hinder?
Templates in how the documents are structured, or templates in how
it's communicated to the patient?
Yeah, I mean, I think, so this was actually a question, as you know, Rod Schmidt is very interested in the different level of communication, the pathologist to clinician communication, whereas we're more interested in the pathologist to patient or clinician to patient communication. And one of the things that I think those templates are confounded by is their organization. So I definitely think if we could think about ways to prioritize what is important in that clinical counter, templates could be constructed in a way that those reports can be more easily interpreted, for sure. I mean, I think synoptic reporting has done a lot to clarify pathology reports in particular. It's definitely easier to look at a report and know where the content you want is, but sometimes that content is in the middle of the report. If I do a lot of kidney cancer surgery, and if I have a kidney cancer pathology report, I usually have to look to the middle of it to find out what the histology was. And so it's not, the things that are in an order that maybe isn't as intuitive to me as the clinician that wants to translate that report. So I think they definitely will help, but I think the content needs to be reconsidered. Any other questions, sir?
I think it depends on what audience you're
Yeah.
talking to. You know, as a physician, as a patient, you really want the report that the clinician or the urologist wants to see.
Yeah. Yeah, I think, you know, these things need to be tailored to the audience. And that's why, again, I don't think we would anticipate making a brand new unifying document. I think that's unrealistic because there are some subtle nuances to a lot of these documents. You know, Colin and I have had a conversation about the Oncoplex results, and there's a lot of content. And so you can't distill that down into a phrase. You can try, but it's just very challenging. And so both are important. You have to have sort of the full content report plus some distillation of that for the target audience. So you can imagine if you had a multifaceted EHR where patients had a specific access route into the EHR, they would be able to access their patient-centered report rather than maybe the full content report. But that full content report is still, I think, a very important health information document. Sorry, I don't know. Oh, okay.
Some of what you talked about today reminds me of the issue of sensitivity versus specificity, right? We would like everyone to understand the information that's provided to them, and we're going to sacrifice specificity in this case, and that is, in my opinion, ability to accurately convey precise information about a medical situation. So in that regard, if you have to take basically medical level information and take it down to, I don't know what your target is, maybe 5th or 6th grade or 7th grade level readability, what are the medical legal implications of misinterpreting the information? Because I would wager that you and I would read a redacted medical paragraph taken to the 6th grade level, and we could come up with a large list of potential interpretations.
Absolutely. So I think that's our challenge. Our challenge is to make sure that, you know, we learned just from simple modifications to the reports that simply just deleting blocks of content can make things better or worse. And so I think we need to understand, number one, we're not trying to replace the standard document, but we need to convey the information that is important to patients without losing its accurate interpretation. So how can we do that? So for a bladder cancer report, I don't think that's that challenging for a simple bladder biopsy report. But for a more complex document, for something like Oncoplex, or frankly, for something like a radical cystectomy pathology report, it's a much more challenging process. I mean, we fully realize that we are trying to bite off a smaller piece because it's easier. So it's a good place to start. Because I think we can change the content of a TURBT report, a bladder biopsy report, simplify it for patients without losing that accuracy, that precision of the content contained within. But I think that's our challenge. And I don't know. And I think that's something that we should probably think about is having it reviewed.
Right, so what are the medical legal implications, right? So the complex description of the lot on which my house sits, pretty complex.
Yeah.
Or power of attorney, or my will, all very complicated documents.
Absolutely.
So isn't it inherent that there's going to be a medical legal risk in modifying the information?
Potentially. And a lot of these documents have necessary reporting, chunks of content. You have to describe certain parts of, laboratory report results or pathology report results. There has to be content that is included in that from a medical legal standpoint. So, I think that's one thing that we have to interrogate, which is it okay if that content is included in a standard report, but is potentially omitted from sort of a patient-centered pathology report? And that's something that we should figure out.
How about informed consent? Informed consent to accept this information in lieu of having a conversation with somebody who knows what they're talking about.
Well, yeah. So I would argue that the intent here is not to replace any conversation with a doctor at all. So the intent here is not to give access to a report that patients can take and completely obviate the need for a sit-down encounter with their urologist or whomever in clinic. For sure not. In fact, we have run into some resistance from clinicians who really strongly believe in what I would consider a paternalistic model of healthcare delivery, where they are concerned that this document threatens their ability to have the information and convey the information in the way they want, with sort of selective inclusion of what they want. And I would argue that that's a pretty antiquated model, but it's a resistance that we're encountering, is that how much engagement and how much empowerment is too much. So I don't know the answer to that. Are you passing again, or are you going now?
No, that's my husband.
Oh, okay.
Ladies first and wife.
Happy life. So, I was wondering, I think this is such an interesting idea. I wonder about two things. Who will make the translation?
Yeah.
Right, so who does that and who pays for that?
Yeah.
That's a big deal. And then the other thing is, if it seems that patients should have access, and the move is to give patients access to their entire health record.
Yeah.
So you shouldn't have to just read your modified health pathology report or lab reports. You're going to really want to be able to get everything.
If you want it.
If you want it.
Yeah. Yeah. No, I think that's definitely true. So who would do it? I mean, I know. Oh, I'm sorry. The question is, sorry, you're right in the light. So I think you probably waved several times and I missed it. The question is, number one, who is going to be responsible for constructing the translations of these reports? So one question that we would have is that something that can be templated out just like the synoptic pathology report is templated out? I would hope so, because I think we could set up some simple algorithms to say if the histology is this, the patient-centered pathology report is going to say this. So I don't think that would be that challenging. How much is it going to cost? It is an additional document, potentially. So I can tell you a pilot evaluation of it is not going to cost very much at all. I mean, it's all sort of pencil and paper done. And I don't think actually if this became sort of a standard thing, I don't think that would be that challenging. I don't think it would require a lot of resources in terms of person time, and I don't think it would require a lot of resources in terms of stuff. So I don't think it would be that expensive. And I don't think that it would be that challenging to build in mechanisms by which a concurrent patient-centered pathology report could be constructed at the same time a standard report is constructed. And I definitely agree that this is not something where, I probably misspoke earlier, that they would only have access to sort of dumbed down documents. But
Yeah, and you probably put a disclaimer that would say, please refer to the detailed report,
Yeah.
blah, 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 for the detailed care information or something.
yeah, and it could be that you have informed consent that, sort of like I don't want to equate it to the iTunes terms of agreement, because that's an incredibly lengthy document, but sort of an informed consent to view your patient-centered pathology report, understanding that this is a distillation of the full report and may not contain all of the information that the pathology report contains.
Related to the same question, my wife and I often think in similar pathways, but I wonder if there's an opportunity to combine this with ICD-10, which will have much more specificity in characterizing diagnoses to the degree of pathology and details, and whether there's a translation template so that clinicians and all of us who are going to be having to deal with this daunting ICD-10 specificity, but maybe there'll be kind of a standard template to translate that, maybe not just for the pathology report, but for the lists of detailed diagnoses.
Absolutely. I full disclosure, know nothing about ICD-10, but I do think that there are a lot of opportunities in healthcare delivery in the next 5 to 10 years to implement informatics-based interventions that may initially make our lives harder, but eventually will make our lives much easier, that make sort of automatic translations from templates using maybe ICD-9 specifications to reports that are part of the standard report or modified reports, depending on what you're trying to do with that information. Yes, ma'am?
From a patient-centered standpoint, I fear that we could end up oversimplifying. For example, I know 3 people who all say they are survivors of skin cancer. One had melanoma, one had basal cell, and one had squamous cell, which all have very different prognoses, have different risk factors. And so if all of their pathology reports say skin cancer, they're all going to believe that they have the same thing.
Absolutely. So, I mean, I think that's where this kind of gets into that same question about the accuracy of the information contained within. And so I think you have to distill it down to an accessible format or accessible terms without making it inaccurate, you know? And so I think, you know, for example, if you assessed general public knowledge about the term melanoma, I think they would probably have a pretty good understanding of that term or recognition of that term. If you ask them about squamous cell carcinoma or basal cell carcinoma, it would probably be a lot more lacking than it is about melanoma. So there may be an opportunity there to take advantage of what terms the public is more familiar or comfortable with versus what terms they're not. You know, I keep going back to the bladder cancer example because that's just the space we're working in. There are multiple variants of bladder cancer that have particularly aggressive behavior. And so we would not want to disguise that in a report. And so one of our challenges will be, how can we represent some of these variants that are important for a patient to understand because it impacts their treatment decisions while still making it an accessible document. Sir?
I was curious about the expert panel that
Yeah.
was convened, and in particular, who was on that panel?
Yeah.
Were these pathologists? Were they clinicians?
So it was a mix. So it included 3 or 4 pathologists locally and then 1 pathologist as part of the Bladder Cancer Advocacy Network. It included urologists, a couple radiation oncologists, and several medical oncologists, and then a couple of PhD level researchers.
And so that's great. That's really nice assembly. I wonder then, did you see any sort of patterns in terms of what they all felt was important?
So I don't know if we have enough numbers to look at specialty-specific patterns, but you know, you can kind of look at the numbers and tell who are the urologists versus who are the medical oncologists, because the domain of bladder cancer that we see is very different. You know, medical oncologists very much see metastatic bladder cancer and at least invasive bladder cancer, whereas we see the marked heterogeneity of non-muscle invasive bladder cancer as well as invasive bladder cancer. And so I think we focus much more on things like stage and grade. The medical oncologists there seem to be, and this is not based on any numbers, this is my gestalt from just going through this when I was making these slides, a focus on some of the quality control issues that are contained in pathology reports, like presence of muscularis in the specimen. That was something that was, I think, inordinately prioritized in some people's responses to our survey. Because yes, it's an important sort of quality control for the accuracy or the adequacy of the specimen that we gave to pathology, but it's not that critical an element for the decisions that we're going to make in most cases. So definitely there may be some different priorities for what elements are important. Thank you. Any other questions? I really appreciate your time and thank you for coming.